Hello, welcome to the week that we talk about intimate partner violence, or IPV, in your Applied Couples and Relational Therapy class at Antioch University. I'm Dr. Katie Zeiger. Our objectives for this week are to define IPV and describe forms, patterns, and dynamics associated with IPV in intimate relationships, to identify assessment, safety, ethical, and contradictions considerations related to IPV and partners therapy, and explain how major therapy models conceptualize and respond to IPV while prioritizing safety and accountability, or at least the major therapy models that we're discussing in the course this semester. If you are either in summer of 2026 or there's a future class where I'm teaching this and you saw my, get my lecture on risk factors, some of this is going to be very familiar. Instead, we're kind of looking specifically just at intimate partner violence for this lecture. I'm going to go over it again. It's always a good idea to go over it again, and we'll go a little more in depth on how the actual therapy models interact with this. Since in that other lecture, we kind of were cramming all of our risk stuff, suicide and IPV and everything else together. Gave us a little bit less time to go over individual model conceptualization. Common acronyms for this side set are IPV for intimate partner violence, DV for domestic violence, IBCT for integrative behavioral couple therapy, which we should be pretty familiar with at this point in the semester, EFT for emotional focused therapy, which we should also be pretty familiar with at this point in the semester. IPV and partners therapy. IPV is a serious partners therapy concern that requires ongoing attention to safety, coercion, accountability, power dynamics, and ethical clinical practice. What is intimate partner violence, or IPV? IPV refers to patterns of abuse, coercion, control, or aggression within intimate or romantic relationships. IPV may include physical, emotional, psychological, sexual, financial, technical, or coercive forms of abuse. We're going to look at the wheel of power and control in a second, and you'll see some of those on there. IPV can involve patterns of power and balance, fear, control, isolation, or threats. IPV occurs across genders, sexual orientations, cultures, socioeconomic groups, and relationship structures. Not all IPV involves physical violence, and not all physical violence functions in the same way clinically or relationally. We'll look at some triage. We'll look at that triage page here in a moment. And then safety, power dynamics, and coercive control are important considerations when assessing IPV. IPV is a form of domestic violence. They are not synonyms. Domestic violence is not limited to intimate partner relationships. So IPV and DV are similar concepts, but not synonyms. The terms IPV and DV are often used interchangeably in clinical, legal, research, and public settings. IPV specifically refers to violence or abuse occurring within intimate romantic relationships. DV is often used as a broader term that includes violence occurring within family or household systems beyond romantic partners. It can also be between roommates and things like that. Definitions of IPV and DV may vary across states, legal systems, organizations, and clinical settings. You should check in on your specific state, what counts as abuse, what counts as violence. These things do vary from state to state. That said, there are still ethical considerations. Even if a state has differing views, there's still therapeutic ethical considerations depending on what's going on. And the therapist should remain aware of both the overlap and distinctions between these terms in clinical, legal, systemic contexts, because language does matter. Why IPV is considered a form of DV. IPV is considered a form of DV because it occurs within intimate, familial, and household relational systems. IPV occurs within domestic, familial, or household relational systems. Many legal systems and agencies classify violence between romantic or intimate partners under DV statutes or protections. So you will sometimes, I shouldn't say often, you will sometimes see IPV in statutes, but very often you'll just see domestic violence. Then IPV is just going to fall under that. IPV may involve shared homes, finances, parenting responsibilities, family systems, or cohabitation. DV services frequently support individuals experiencing IPV related abuse or coercion. And we'll talk about some of those services later on. DV can occur within many family and household relationships beyond intimate or romantic partnerships around why DV is not always IPV, right? IPV is intimate partner violence. Domestic violence is not always intimate partner violence. So this can be between family members or household members, like roommates. They're not romantic or intimate partners. It can involve parent-child violence, elder abuse, sibling violence, caregiver abuse, or violence between extended family members. Some DV statutes include household members, co-parents, roommates, or family systems beyond romantic relationships. Again, you're going to want to check out your individual state to see what the case is, or the states that you practice in to see what the case is. The relational dynamics, power structures, developmental considerations, and treatment approaches may differ depending on the relationship context. So, just a quick IPV versus DV. IPV, the spouse physically assaulting their partner during conflict, a dating partner using coercive control, threats, or isolation, an intimate partner monitoring finances, communication, or movement to maintain control, sexual coercion, or intimidation within a romantic relationship. So, examples of IPV, DV, adult children physically abusing aging parents, sibling violence within households, caregiver abuse towards a dependent family member, violence between family members living in the same home but not in an intimate relationship. So, roommates. And those are all examples of DV. So again, there's overlap, but they're not necessarily the same thing. We're also going to talk about coercive control. This is an important concept when it comes to IPV. IPV is most often defined more by patterns of coercive control and fear than by physical violence alone. Physical violence is definitely IPV, but we can have IPV without violence being present. And sometimes it can be harder to assess for that. You may get quite a bit into working with a couple before you realize that there is escalation around coercive control. So it's an important thing to try and keep an eye on. IPV is not limited to physical violence. It may involve ongoing patterns of control, intimidation, surveillance, isolation, or domination. Coercive control may include monitoring communication, restricting finances, limiting movement, threats, humiliation, or manipulation. Survivors may experience fear, hypervigilance, dependency, or loss of autonomy, even without current physical violence, or there ever having been physical violence. Coercive control often escalates over time and may increase significantly during separation attempts. It also will likely increase anytime a therapist tries to bring both partners to an equal space, which is why it's so important that we're assessing for it and trying to recognize it, even in the absence of physical violence. Because what I have seen repeatedly when I've worked with couples who didn't have physical violence but had coercive control is that anytime I or a supervising therapist or whoever tries to bring the couples to like a more even space, so like vulnerability, of empathy, of trying to like bring folks to this more like neutral, equal space, that we see escalation, sometimes in therapy, but often outside of therapy, which is why we need to continue to be assessing for this and checking in for this, because it can be very easy to miss as just normal fighting or things like that, when what is actually going on is a escalation response to the attempted equality in therapy, with escalation of coercive control attempts outside of therapy. Therapists should assess for patterns of power and control, not only isolated incidents of conflict or aggression or violence. So here's our wheel of power control. There are many more of these wheels, and like one I use very often with my clients, since I work with a lot of trans and gender queer folks, there's a gender neutral version of the power and control wheel that I use. There are a lot of variations of this, and you're welcome to reach out to me or to Dr. Listinia Francis, and I'm more than more than happy to give you access to the versions of the wheel that I have access to, or to share links to where I know to find those. So this is our wheel of power and control. And we've got coercion and threatening, makes and or carries out, threats to hurt me, threatens to commit suicide, threatens to report, embarrass me, out me to an agency or others, threatens to leave me, pressures me to commit illegal actions, right? So coercion and threatening. Using intimidation makes me feel afraid or unsafe with actions, gestures, and or looks, throws things, breaks things, damages my property, abuses my pets, displays and talks about weapons or using weapons. Using emotional abuse puts me down, makes me feel bad about myself, calls me names, makes me think I'm crazy, misrepresenting or overreacting. You might have heard like the term Darvo, and a little bit of what we're talking about here is Darvo. A little bit of what we're talking about here might be gaslighting. Plays mind games, humiliates me, makes me feel guilty or ashamed. Using isolation controls what I do, who I see, what I read, where I go, who I talk to. Limits my volunteer, religious, or outside activities. This can also include limiting work, monitors my behavior and my communication, uses jealousy to justify actions. I've also seen something that I don't know where to put it exactly, but like I've mostly in my head kind of filed it under isolation, where before you have a big thing coming up, let's say at work, you've got like a big presentation, the person might like pick a fight the day before. And so like undermines work, which has the outcome of like harming your outside life, right? We see this maybe with school, the same thing with school. Like we're going to pick a fight right before we have a big, a big project due or a big paper due. Pick a fight right before we have to go take boards, before we have to go do career examinations, things like that. Maybe is going to like pick a fight or do something else that throws a wrench in like going to see family or that just makes you really like upset and like strained the whole stressed the whole time you're seeing family. So again, it's gonna interact negatively with your life outside of that person. Minimizing, denying, and blaming makes light of the abuse, doesn't take any of my concerns seriously, denies abuse ever happened, shifts blame for the abuse to me, saying I caused or deserved it. So this is kind of that other part of Darvo. Using children makes me feel guilty about the children, uses the children to relay messages, uses our visitation arrangements to harass me, threatens to take the children away. There is an app I didn't include in this slide set, but that I often suggest. I think it's called our. Um, yeah. So our family wizard. This is one that like I first was introduced to when I was an intern, or maybe just like an associate therapist. But I was involved in a lot of like foster things and with divorced families and stuff like that. I was at a domestic violence shelter, and this was something that would sometimes be like court ordered to be used. And specifically, like all your communication, everything you do tracks through here. And like, obviously, I don't get any kickback or anything like this, but I do still occasionally suggest this to families. There is a fee waiver program that you can apply for depending on what your income and stuff is. Some of the courts use it. You might ask it, they can ask if their court uses it, but this can be included as part of, or in some courts, this can be included as part of the court order for like communication and stuff for divorced or separated families. And all the communication gets done through here. So there's no texting outside, there's no emailing outside. Everything gets tracked through here, which just is very protective. It makes things go a little bit easier for folks. So this is an option. If you run into a situation where we're using children, granted, Hopefully, at this point, we are probably not doing um, intimate partner therapy. We're probably working with them separately at this point in some way. But that is a tool that I wanted to mention. Using privilege treats me like a servant. Get it back to there we go. Using privilege treats me like a servant, acts like the head of the household. If that's not, your agreed upon religious or cultural setup, makes all the big decisions, defines each person's role in the relationship, uses gender, race, class, or sociological stereotypes against me. Using economic abuse keeps me from getting or keeping a job, makes me ask for money, gives me an allowance, takes my money, refuses to let me know about or have any kind of access to our shared income. So this is our wheel, and these are just some examples, right? Like you will have other examples that may fit in one or more. That one of the examples I gave for like picking before a big presentation at work could go under isolation. It could also go under economic abuse. This is our wheel of equality. This is kind of what we want it to look like, right? So, fairness in negotiation seeks mutual, satisfying resolutions to conflict, accepts changes, is willing to find compromises. Non threatening behavior talks with me and acts towards me so that I feel safe and comfortable expressing myself and doing things. Respect listens to me non judgmentally, is emotionally affirming and understanding, values my opinions. Trust and support supports my goals in life, respects my right to have my own feelings, friends, activities, and personal opinions. Accountability and honesty accepts personal responsibility for self, acknowledges past uses of violence, admits being wrong, communicates openly and truthfully. Responsible parenting shares parental responsibilities, is a positive, nonviolent role model for the children. Shared responsibility mutually agrees on a fair share of work, practices regularly making family decisions together, listens well, and accepts honest feedback. An economic partnership works together to make financial decisions, make sure both of us see equal benefit from financial arrangements. Or maybe not equal benefit, but equal sacrifices. Depending on the situation. So this is kind of our ideal. This is where we want to get. And depending on what's going on, as we try to achieve this more so in relationships, we might see these increase. And so we need to be tracking that. If we're having escalation around power and control, especially coercive power, we need to be tracking that. And that very well may be a contradiction for couples therapy. In cases of severe IPV, helping the couple often means prioritizing safety, stabilization, accountability, and appropriate referral rather than continuing conjoint couples therapy. When I first started out supervising, there was one time I was supervising for a group at a different college than Antioch, and I hadn't realized that I hadn't explained to the students why it's a contradiction, right? I just told them like we can't see clients if there's domestic violence or interpersonal violence, like we can't see them as relational groups. And I hadn't explained why. I don't know if I just assumed they'd already had that conversation in one of their actual classes, but I had a couple of the students come to me and were like, well, but they still deserve therapy even if they're not perfect. And I realized that they had this idea that like we were like withholding therapy because they'd like failed somehow. And that is not. I just want to be really, really clear that and like that was like a perfectly reasonable thing for them to think, given that like it had been explained to them, right? But that is not what we're doing. We're not withholding therapy because they're not perfect. Nobody's perfect. I'm not perfect. You're not perfect. We are appropriately recognizing that continuing therapy is a safety risk. So couples therapy, partners therapy can and will escalate patterns of power and control, patterns of coercive control, patterns of physical violence, domestic violence, intimate partner violence. in a lot of cases. So it is a safety risk to continue seeing couples once you recognize this is here. That's why we need to check for it at the start of sessions, which we'll talk about in just a moment. And we need to continue assessing throughout sessions. And every so often, like you'll think things are okay, and something will kind of trip those valves, and then you need to reassess. And that's why it's always like an ethical good to make sure we're consulting, we're talking to others. I talk to colleagues all the time. We still need to follow HIPAA in those cases, obviously. Um, but we can consult, we can talk, and get an idea of like what we're seeing. If we're not totally sure, like what are we seeing? Because we want our clients to be okay and as safe as possible. And intimate partner violence, coercive control, physical violence, those are all things that can be contradictions for couples therapy. Not because they're not good enough, not because they're doing something wrong, but because partners therapy, couples therapy, relational therapy itself actually increases escalation of those things. And there's a lot of different theories around why that happens. The one that makes the most sense to me is if we don't have some way to individually address and work on not needing to keep control of a situation, then because when we talk about abuse, when we talk about violence, we're talking about controlling the situation, right? That's why we talk about power and control. That's why we talk about coercive control. So we don't have some way for that individual to work on that themselves. They're going to continue to spiral around that and want to keep that control. And and as therapy, part of what we're trying to do is make things equal, make things at least equitable, right? And make things like even and fair and like empathetic between the partners and connected and like well connected and equally connected between the partners. And that erodes control, right? When we do those things, one person having more control gets eroded in this like more healthy model of a relationship. At least in the overall relationship, right? We may still have some spaces where somebody has more control here or there, but in the overall model of the relationship, things become more equitable, more equal. And that is going to be responded to from the partner who wants to control things or who needs to control things, depending on what's going on with them, with this escalation of control. And so as therapy works to make things more and more equal, they're going to escalate higher and higher and higher. And it's going to get more and more dangerous. So we don't stop therapy for IPV to punish people or because they don't deserve to have therapy. We stop it because it's a safety risk and we want everybody to be safe. We want the client who's the most at risk of the folks to be safe and okay. And we also want the other person to have a chance to do better. And if something escalates past a certain point, they may lose that chance to ever do better and ever be okay. So that's very explicitly why it's so important that we are careful to be assessing for this, and then we stop therapy if we have contradictions. So take a quick second to look at this IPV checklist. The screen a little bit bigger. So this is something you have access to both inside of you can just click on this link right here, just type it in, tinyurl.com, IPV triage. You can also email me. I'm happy to like send you this as a downloaded form. So this is just this little triage handout that talks about the different like rapid intake and triage checklists. This is a brief guide for use in combination with supervision and consultation. This is around distinguishing situational couples violence from coercive control and intimate terrorism. Situational is not necessarily a contradiction, whereas coercive control, intimate terrorism is. So this has just been to help you determine whether conjoint or relational couple therapy is appropriate when IPV is disclosed or suspected. Again, not a standalone guide. This is just kind of a cheat sheet to be used in consultation with practice in group settings. So you've got some initial safety and screening questions. around fear and safety, control monitoring, severity of violence, pattern of escalation, substance use and mental health, separation and retaliation risk, responsibility and remorse. And then we want to look at that pattern assessment from Johnson's typology indicators. So motive, frequency, control tactics, injury, fear, responsibility, therapeutic potential. And then we're going to make decisions. If there's evidence of coercive control, fear, threats, or escalating violence, we're going to stop conjoint therapy. We're going to do safety planning. We're going to do individual treatment referrals if they don't already have individual therapists. If they have individual therapists already, then you're just going to note that, and you're going to like both note that when you reach out to them, and you're going to note that in your own notes, and that they already have individual therapists. And there's no sustained fear. Both partners express remorse. If the violence appears reactive, conflict related only, it's not necessarily a contradiction. Now, we're going to be careful. We're going to proceed cautiously. We're going to do ongoing safety monitoring. But I have certainly worked with couples where we had situational violence that I was able to continue in therapy with, clear up to the point where like we had a pretty good situation in the relationship and a pretty healthy relationship going. And they like graduated from couples therapy, at least for the time being, right? That said, I definitely had couples where I thought we were looking at situational and like eventually realized we weren't looking at situational, at least we weren't looking at situational anymore, and that we were into, escalating violence or coercive control. I've also had couples where I didn't even recognize there was no violence. There's no physical violence. There was no nothing that I would consider like emotional abuse, or nothing I recognized at least as emotional abuse at the time. And it took me a little bit to realize that despite there being like no violence, that we were absolutely into coercive control. Not just coercive control, but we were into escalating coercive control around therapy. And then with an unclear or mixed presentation, we're going to conduct additional assessments and measure and use tools. And we'll talk a little bit about these. And we'll talk specifically about one that I think we should be using regardless every time to assess for this. Or every couple, I guess, not every time. And then even with situational violence, or like situational conflict, we're gonna establish a no violence safety plan. We're gonna reaffirm autonomy to stop sessions if unsafe. We're gonna use structured models. We're gonna reassess safety each session. And we're gonna coordinate with IPV specialists. And I want to this gets a little bit sticky, but I want to remind everybody that if we stop therapy due to coercive control, if we stop therapy due to escalating violence, we don't tell we only tell the at-risk, the at-risk partner. That's what we're doing. The other partner, we just tell them that that there's a contradiction for therapy and that we are not continuing partners therapy, because that stopping of the therapy can then end up blamed on the at-risk person and can raise the risk for the at-risk person being seriously hurt. So we're going to do safety planning there, even if we've previously done one of these. And even if in our head we can go, okay, well, this other partner can probably knows what we're doing. Probably, maybe, I don't know. But we're still going to treat it that way because that's our best case scenario for moving forward with it. Okay, so this is your IPV triage checklist. Please take a little bit to check it out. So again, IPV can contradict partners therapy. When fear, coercion, or ongoing abuse are present, safety must take priority over conjoint relational work. This is not a punishment. This is not because they're not good enough. This is not because they don't deserve therapy. They absolutely deserve therapy, and we should be referring to individual therapy if they don't have their own individual therapies already. But this is about safety and risk. Again, not all IPV is an automatic contradiction for couples therapy. And assessment should consider context, severity, patterns, fear, coercion, and safety. Current physical violence or abuse is generally considered a contradiction for couples therapy. Depending on, it's definitely any sort of person to person physical violence or abuse. Some of the other things that we might consider physical violence, like throwing things and stuff like that, we may assess more individually. But I do very much agree that like any sort of person to person, one person's hit the other person. One person has like definitely like strangulation. We're going to talk about strangulation here in a moment. Anything physical, like at that point, that is a contradiction for couples therapy. The second I've heard that, I've already kind of in my brain gone, oh, okay, therapy is contradicted. I'm still going to go through all of the steps. I'm still going to go through all the stuff, but I'm going to refer them out. And then if we get to a point where we're not physically violent and haven't been for a while, then maybe we can come back and try couples therapy again. So severe emotional, psychological, coercive, or controlling abuse may also contradict conjoint treatment, especially if we notice escalation around therapy. So we may initially assess for this and go, okay, well, I don't think it's a contradiction. But then every time they come back, the story seems a little bit bigger. We're looking at escalation, and that's going to be a contradiction. When significant fear, intimidation, coercive control, or safety risk is present, couples therapy may and often will increase danger rather than improve the relationship. Therapists should continually reassess safety, coercion, and appropriateness of treatment structure throughout care. And this doesn't have to look like we're going to go through the whole battery of assessment all over again. It's just going to look like if there's a red flag, we're going to like check in on that. If I notice something that feels odd or feels off, I'm going to go do a consultation with somebody and get like outside, right? Like if I've been part of this therapy unit for a little bit, I may not be like accurately assessing things as well as I could. Just because like all therapists are human, right? So I'm going to go talk to a colleague. I'm going to go do a consultation and kind of put those facts and lay those facts out and see what they say. Because they may be like, man, this is not okay. Or maybe the opposite. They may say, you know what, that sounds okay to me. Right. And then in our notes, we're going to note that, one of my friends that is also a psychotherapist that I consult with a lot is Dr. Jacob Sandoval. So I'm going to write, after consultation with Dr. Jacob Sandoval, came to the conclusion that blah, 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 blah. So again, why partners therapy can escalate abuse in IPV cases. In abusive dynamics, conjoint therapy may unintentionally increase danger, coercion, retaliation, or victim self-blame. I talked about this a little bit before, that we have some theories around this. And there's a lot of different ones. And I kind of explained the one that I thought was the most, but there's many other ones. So joint therapy may unintentionally provide abusive partners with like additional information, emotional leverage, or opportunities for retaliation outside a session. Therapy may reinforce like victim self-blame or pressure into unsafe disclosure, vulnerability, or reconciliation. May make the person feel like they're at fault, or if they just did things better, right, then this wouldn't happen. Abusive partners can weaponize therapy language. I have seen this in an unfortunate amount of times, where abusive partners have weaponized therapy language, emotional disclosures, or interventions to maintain control. Or weaponized, I've also seen like folks weaponize their individual therapy as a way of like presenting themselves as more at risk. And so maintaining control that way. And that can be hard to see because sometimes that is true and that's not a control thing. And sometimes it is a control thing and we just have to do our best. Necessary levels of safety, accountability, and good faith participation are likely just not going to exist in abusive dynamics, right? So if we only have one person that is actually engaging in therapy from a good faith participation, if we only have one person that's trying to be accountable and compassionate and empathize and the other person is not, sometimes like the other person doesn't even recognize that they're not, right? And so that can get a little bit sticky. Again, we just have to make our best clinical judgment. Then therapy is just not going to be successful. And then safety, stabilization, accountability, and appropriate individual or specialized services should always take priority before considering conjoint relational work. Now, if you see somebody, you refer out, and they come back in like a year, and they're like, we haven't had any sort of physical violence or abuse for a year. And and there's been no course of control for a year. We did all of these other things. We went through these individual therapy programs, went through this individual stuff. I would be comfortable taking them on again and reassessing and working with them again. Now that doesn't happen a lot, unfortunately, but like that would be okay. But for the time being, we would not want to be continuing relational therapy. Okay, deep breath. This is a lot, right? Yeah. Okay. So we're going to kind of switch gears a little bit and we're going to move on to talk a little bit about how partners therapy models approach IPV, specifically the partners therapy models that we've been focusing on this semester. So historically, some family and partner therapy approaches have been criticized for incorrectly framing abuse as this like mutually created relational problem rather than adequately recognizing power imbalances, coercive control, accountability, and victim safety. And that's just like something we need to be aware of. We need to talk about. We need to know is the case in our field. We didn't always understand that relational therapy would increase abuse and could increase abuse. We didn't always understand that it could cause escalation. And we didn't always do a very good job of dealing with that. So please learn from the mistakes of those who came before you when it comes to this. And also, like, don't minimize the fact that, like, that was the case in relational therapy. That we know this about our field. So we're going to start off with emotionally focused therapy, EFT. So EFT conceptualizes IPV through attachment dynamics, emotional regulation, and negative interactional cycles, while recognizing that attachment needs do not excuse abusive behavior. Therapists assess for fear, coercion, intimidation, power imbalance, and safety before engaging in deeper attachment work, because otherwise therapy is just probably not going to be as successful. EFT is generally contradicted in cases involving ongoing coercive control or current physical abuse. Treatment emphasizes de-escalation, emotional regulation, accountability, and emotional safety. And remember that like those things likely can't happen because a lot of that is meant to bring people even to each other. And that will cause escalation instead of de-escalation. If we've got active cases of coercive control, active cases of physical violence. And then therapists should avoid framing IPV as a mutual cycle when significant power imbalances or abuse are present, which is something that like there's a risk for when we talk about cycles in EFT. And then if EFT is your model, I very much encourage you to look more into this, get in a better idea about what this might look like for you working with EFT and assessing for IPV, because you should be doing it with every single, couple or partner group that you see. The Gottman method. The Gottman method emphasizes assessment of conflict patterns, emotional escalation, physiological flooding, and destructive interactive styles. Therapists assess for severity of violence, coercive control, intimidation, fear, and safety concerns before beginning conjoint work. The model distinguishes situational conflict from more severe controlling forms of IPV. In fact, this model has like a huge emphasis on conflict cycles, right? So conflict in and of itself is not a contradiction. But specifically what we're looking for is this coercive control and like physical violence and severity of that, and that it's not situational. Gottman can focus on conflict regulation, repair attempts, emotional regulation, and communication skills when conjoint work is appropriate. But again, we're doing these repair attempts and working on these like communication skills when we have ongoing abuse. This is going to get weaponized. This is going to cause escalation. And then current severe violence, fear, or coercive control generally is contradicted for Gottman couples therapy. Again, if you're going to use the Gottman method, I very much encourage you to look a little bit more into this than what we can go over in one slide set, right? The developmental model conceptualizes IPV within struggles related to differentiation, emotional regulation, relational maturity, and self-development. Therapists assess the couple's ability to tolerate emotional intensity, autonomy, accountability, and vulnerability without aggression or intimidation. IPV may reflect difficulties managing dependency, shame, control, emotional overwhelm, or developmental stress. This model emphasizes emotional responsibility, flexibility, relational functioning rather than blame or pathology, which can be a way out of taking accountability if we've got ongoing abuse happening. So again, we don't want to continue this model if there's ongoing coercive control or physical violence. Current abuse, coercion, or unsafe power dynamics may contradict conjoint treatment. Again, look more into this if this is your model. Imago relationship therapy. Imago therapy explores how earlier relational wounds and unmet attachment needs may shape conflict and emotional reactivity within relationships. So again, we are well aware that conflict occurs. Conflict is not a contradiction in and of itself. We must assess whether structured dialogue can occur safely without intimidation, coercion, or retaliation. The model emphasizes empathy, validation, emotional attunement, and reducing reactive escalation. And this won't happen. We will absolutely see escalation if we try to use this when somebody is still actively trying to hold on to control through coercive or physically abusive means. Imago interventions are not appropriate when one partner cannot safely engage vulnerability or assert boundaries. And attachment wounds or relational pain may help contextualize behavior, but they do not excuse abusive actions or coercive control. Please feel free to reach out to me or to look more into this if this is the model that you think you're going to be using. Object relations therapy. Object relations therapy explores how early relational experiences, attachment wounds, defenses, and internalized relational templates influence IPV. We must assess for projection, emotional volatility, fear, splitting, shame, and control patterns of domination. Remember, these are all like projection, right? Splitting, these are normal parts of this model. So again, these are not contradictions in themselves. It's these control patterns, right? IPV may emerge within attempts to manage vulnerability, abandonment fears, emotional dysregulations, or threatens to self-concept, or just threatens to their, if we've got uncertainty and tolerance, or if we just really want to have control of the situation. This model emphasizes insight, reflective capacity, emotional regulation, awareness of relational patterns. So if we have one person who is choosing not to, or who just simply cannot engage in good faith, this is going to put the person who can at increased risk from that, so the at-risk person will be at increased risk. And severe abuse, intimidation, and coercive dynamics may prevent the level of safety necessary for this sort of insight-oriented work. So again, if this is a model you think you're going to use, please look more into it. Integrative Behavioral Couple Therapy, IBCT. IBCT conceptualizes IPV within recurring behavioral, emotional, and relational patterns while recognizing the importance of safety and accountability. Must assess the severity, frequency, context, fear, coercion, and consequences of aggressive behaviors. The model balances emotional acceptance with behavior change and accountability interventions, which will not be successful and will lead to escalation if we've got ongoing coercive control or physical violence going on. IBCT may focus on emotional regulation, communication, distress tolerance, and interruption of destructive interactive cycles when appropriate. This interruption will lead to escalation if what we're looking at is coercive control or physical abuse. So current physical abuse, coercive control, or significant fear will contradict this working with this model. Again, if IBCT is a model that speaks to you, you think you're going to be using, please look into more how it deals with intimate personal violence. And then if we talk about common therapist pitfalls in IPV work, so systemic understanding should never come at the expense of safety, accountability, or power awareness. While one of our huge strengths as therapists, as LMFTs, marriage and family therapists, couples and family therapists, is this like ability to look at things systemically. Looking at things systemically does run the risk of kind of excusing away accountability and saying, okay, well, it's both and situation, right? And we need to be really, really careful that we do not do that when we're talking about intimate partner violence, because intimate partner violence, looking at it as a both and, looking at it systemically can lead to, not assigning accountability where it belongs, and can lead to kind of thinking that, oh, well, it's nobody's fault. And if I just do this, and that's just not how it works in relational therapy. Relational therapy, can and will escalate that type of coercive control and domestic violence. So we went treating coercive abuse as merely a communication problem. It's not something we should be doing. Overemphasizing mutual responsibility when major power imbalances exist is not something we should be doing. And I've seen this, um, unfortunately, often. I have seen um, seen clients themselves, especially clients who have done a lot of therapy, a lot of individual therapy, a lot of other types of therapy, who have kind of labeled um, coercive abuse and coercive control as like their communication style, or blame it on their communication style, or blame it on like their relational therapist or their partners not understanding that is their communication style. Um, and like that's just not something, whether or not we think communication is part of the problem or part of what's going on here, that's not a trap that we need to let ourselves fall into, because regardless of like what is actually causing the issue, we're still looking at coercive control, we're still looking at escalation, and we're still looking at the at-risk partner being more at risk. The same with like overemphasizing mutual responsibility. I have seen folks, I've seen both therapists do this. I've also seen clients, especially like heavily therapized clients, do this on both sides. I've seen clients that, from my perspective, are at risk, who really feel like if they could just do X, Y, Z, it'd be better, and it's their fault because they can't. Or the other person weaponizing that as a way of making it either mutual responsibility or entirely the other person's responsibility, and creating this increased power imbalance. We don't want to encourage unsafe vulnerability, disclosure, or reconciliation. We don't want to minimize fear, coercion, stalking, or intimidation. We don't want to confuse explanations with excuses or make people feel like because it's been explained, they have to excuse it away or be okay with it. That because it's understood, they have to excuse it away or be okay with it. We don't want to overlook cultural systemic barriers to safety, because these are very, very real. So we don't want to assume that just because somebody's a man, that like this can't happen to them, right? We don't want to assume that because somebody, or we don't want to miss the fact that like because of the religion somebody's in, they may not know how to navigate these safety issues or be able to navigate them in the way that like we might think they should. And so we want to work with that. And we need to be careful that we're not working outside of scope of competence. And I want to be very, very clear that for every LMFT starting out, working with a couple who's actively in like escalation cycles of coercive control, who's actively in escalation cycles of physical abuse, is outside your scope of competence. There are some folks who are working out some couples therapy protocols that might work for this, but those are not ones that we are teaching, and those are not ones that have been well studied yet. And it is absolutely something that you'd have to get additional training for to be within your scope of competence, if it can be. So assessing for IPV in partners therapy. So again, deep breath. We're going to move trains of thought again. We're going to go from looking at the individual therapy models to kind of assessing for what is IPV and like what this looks like. So core assessment areas in IPV work. IPV assessment should evaluate both immediate danger and broader patterns of power control and safety. We're going to check for violence or abuse presence, frequency, severity, and escalation, and history. We're going to check for fear, intimidation, coercion, control within the relationship. We're going to check for emotional, psychological, sexual, financial, technological abuses. We're going to check for strangulation, choking, history. In research, this has repeatedly come up that if we have strangulation, and I would argue that if we have any situation where we have like done something that like we have attacked the person in a way that can be fatal. But in the research, we specifically see it tied to strangulation. So if somebody's come after you with a knife or something like that, I would also argue that falls in here. But in research, we've seen this specifically tied to strangulation and choking. That like this is a pretty severe history, and that we likely have a contraindication of therapy. So any injury history, any threats, stalking, or weapon access. We're going to assess for substance use, mental health concerns, emotional regulation concerns. We're going to assess for child and independent safety, which may mean that we're doing a mandatory report, right? If we have intimate partner violence, if we have domestic violence, and children have witnessed that, that is a mandatory report in every state that I'm aware of. And we're going to check for pet-related safety concerns. And then we're going to check for readiness, barriers, available support systems, and for safety planning. So, individual assessment and screening. Clients may not disclose IPV immediately, especially when fear, shame, coercion, or systemic barriers are present. IPV screening should generally occur individually rather than conjointly. And this can feel like a little bit weird when you're working with couples. I had a new couple last week that were going through like the HIPAA spiels, and I get to like the like how I handle secrets. And one of the clients like kind of laughed and was like, well, when would you ever be with us separately for us to tell you a secret? And I was like, well, actually, we're going to do that next week. Right. So, and you'll often see this like, well, we don't need that. And so I always explain it as like, and I know that that may not be a consideration for, and I'll just say something like, you know, there are things that you may tell me individually about your history, about your past, about like what's going on for you that you maybe aren't at the place of disclosing to your partner, or you wouldn't disclose in the same way. And I know that may not be the case for you as a couple. That may not even be a consideration for you as a couple, but it is for some couples. So I do this with all couples, right? So I'm not even bringing up the part of what we're going to look at is IPV. We're just talking about the fact that like there's some practical reasons why we're going to meet separately at least this once. So separate assessment may improve honesty, disclosure, and safety. Therapists should assess for fear of retaliation or monitoring by the partner during that session. So I will often ask people to like turn their camera around real quick. Just let me see the room, right? Let me see what's going on. Just so that I can check with, you know, that like they're alone and that they can like talk to me without fear of the person being there. If they're still acting a little bit off, I might suggest like maybe be type, because I have had a case before where like there was nobody in the room, but they knew their partner was on the other side of the door and could hear them, right? Screening should be ongoing rather than limited to intake. So we should be checking in pretty regularly. At least if we're like ongoing, we're going to be at least be doing this once a year when we like redo our diagnostic screenings. But we should probably be doing this whenever like something pings our bell. And we certainly should be doing consultation and things like that whenever we see like little red flags. Therapists should avoid assuming IPV is absent simply because the clients aren't disclosing it, right? Because they don't know you yet. They don't know if they can trust you. And sometimes they don't even know that what they're experiencing is IPV. And then cultural, gender, and systemic barriers may impact disclosing and reporting. Right, like I've definitely seen like religious barriers and things like that to reporting, or even knowing that's what they're experiencing. So lethality and high-risk indicators. Certain IPV risk factors are strongly associated with increased lethality and require immediate safety-focused intervention. Escalation in frequency or severity of violence, when we're talking about physical violence, injury history, strangulation, choking history, threats to kill self, partner, children, or pets, or having, you know, injured any of those, weapon access or threats involving weapons, stalking, so, you know, histories of stalking or current existence of stalking, surveillance, or obsessive jealousy, forced isolation or restriction of movement, resources, right? That's like coercive control. Separation violence are threats after attempts to leave. Remember, when is the most dangerous time statistically for somebody who's trying to leave an abusive relationship? It is right after they've left, right? So we're going to check for that sort of history too. We have some different risk patterns and protocols for technology and telehealth safety risks. Um, Technology can support and increase, can both support folks and can increase risk for individuals experiencing IPV. And that's just kind of a space that we're trying to figure out right now. So abusive partners may monitor phones, locations, shared accounts, devices, or online activity. It's something that we need to be aware of, that there's a possibility of, and we need to talk to our clients about. Therapists should assess whether clients can safely participate in telehealth sessions without monitoring or retaliation. Shared devices, smart home systems, tracking apps, location sharing, these may all increase safety risk, right? If we've got cameras, increasingly we have camera devices inside our homes. And we need to recognize that like those can be recorded. Um, Discuss privacy, headphones, safety, safe communication methods, and emergency planning when using telehealth. Digital safety and technology coercion should be considered as part of ongoing IPV assessment and safety planning. Something I will often do with safety planning is I will ask people to make a new email just in case. Just so that they've got an email that like it's extremely unlikely their partner has access to, that safety plan is going to, and that they can maybe send other things to as they work towards safety. IPV risk and marginalized populations. Systemic oppression can significantly shape both IPV experience of risk and access to safety or support. The domestic violence shelter that I used to work at, we could not get the board to agree to allow like all genders, right? We had men and we had women, but we didn't really know what we were supposed to do with like non-binary folks, and like we could not get them to agree to that. So, and that was really one of the only domestic violence shelters in that location. So that was a barrier to safety, right? Marginalized individuals may experience additional barriers to safety reporting, shelter access, legal protection, healthcare, or community support. Racism, ableism, transphobia, homophobia, immigration status, poverty, and discrimination may increase vulnerability and decrease access to resources, or decrease the belief that you can access resources, right? Or how safe those resources are. Survivors may fear being outed, deportation, discrimination, family rejection, police violence, or loss of housing or custody. Therapists need to avoid assuming all clients have equal access to safety, financial independence, or systemic protection. And we need to have like culture of humility and systemic awareness when it comes to these sort of assessments and interventions. So, safety planning. Safety planning is really, really important. Effective safety planning focuses on increasing safety and options rather than pressuring clients into immediate decisions. Safety planning should be collaborative, individualized, and practical. Plans may include emergency contact, shelters, transportation, medication, documents, finances, pets, children, and code words. Therapists should assess technology, safety, and risks related to digital monitoring or shared accounts. Safety planning may involve preparation, even when a client is not ready or able to leave the relationship. Safety planning should prioritize autonomy, confidentiality, and realistic options available to the client. And anytime you've got coercive control or escalation around coercive control or physical violence, we should be doing safety planning. The only possible exception to this is in scenarios where folks are already living separately. So let's say you're working with a couple that is already living separately. I'd still be a little bit on the fence, just depending. I'd want to like personally assess exactly where we were in that plan. But in that case, maybe the mitigation of risk is just like talking to the client. You know, if there's physical violence, I probably would still do a safety plan regardless. If there's not physical violence and we're dealing with like some coercive control, but the person's already living separately, is already separated, is already on their way out, that's a case where like maybe you can skip the safety planning, but I'd be really careful. I'd still be doing all of the other resourcing and all of the other stuff. But in probably 95 out of 100 cases, you're still going to safety plan. The second you realize there's coercive control, or there even might be, we're going to go ahead and safety plan. So assessment tools can support IPV work, but clinical judgment, safety awareness, ongoing assessment remain essential. you're just gonna like work within those tools, right? These sort of tools are not always gonna pick up on coercive control, right? Some of them are like very focused on physical violence, and we're going to talk about one of those versus like some other types of coercive control. So we just need to be aware of that. So we can use structured screening or risk assessment tools to support assessment safety planning, but you're still the clinician. You still need to be paying attention to stuff. Some commonly used tools are the danger assessment, HITS, CTS2, and other IPV specific screening measures. We've got some links on that in some upcoming slides. Assessment tools should supplement, not replace our judgment and our ongoing safety assessment. We should remain aware of cultural limitations, underreporting, contextual factors influencing assessment outcomes, and collaboration with IPV agencies, shelters, legal advocates, and crisis resources are still going to be clinically important. And we'll talk about that here just a second. So I've included a couple of safety plan links. This one takes you to kind of an all-in-one safety plan from the National Center of Domestic and Sexual Violence. So this is something that just kind of has everything together that you can use. I really like, so one of the states that I practice in is Wisconsin. I really like the Wisconsin Friends Incorporated safety plan page. They have them in both English and in Spanish. And they have like a different page for different situations. So you can kind of customize it to your specific client. And I think that's pretty awesome and like a really good idea. So we can do safety during a violent incident. We can do safety when preparing to leave. We can do safety for the safe pack, that, backpack or bag that we're going to take. Safety in the residence, safety for children, safety during court, right? Like we can just go on and on. Safety with an active order of protection, safety after my abuser is released from custody, safety at work, safety at school, safety for my pet, safety with technology. Remember, we talked about the technology is kind of a new and ongoing thing we're working out. Financial safety, emotional safety, right? So we've got all of these, and then we have all of these in Spanish as well. So I really like these since it's more of like a customizable approach. Both of those are linked here. And you can also reach out to me. I have these and some others saved. And then this is a good site for finding a local shelter and hotlines. You're going to use your zip code or city and state. So I'm just going to use one here in Aurora, Colorado. So if I put in 80016, which Colorado is where I live, in the Denver Metro. So this takes you to lunch and it'll tell you if there's a hotline. So here's a local hotline that has pet options, right? Here's a local hotline. This one's just got a phone number for calling. Safe House Denver has a hotline. Oh, that's new. I hadn't seen that before. So that's something cool to do. But like we have, listed this. I really like this for finding local options and for finding local hotlines. This is a good site for this. We're going to go over another site here in a second that also has a little bit like this, but I prefer this one. But both are good ones for you to have. So domesticshelters.org. It's definitely one that we want to keep an eye on. And then we've got the National Domestic Violence Hotline in the USA. It's 1-800-799-7233, which spells out SAFE. You can also text START to 88788. And you also can go to the hotline.org. So the hotline, this is in case we don't know what this is. So all of these like pop-ups we've seen on some of these sites, the red X is so that people can very quickly escape, get off of this in case like their partner or somebody comes in, so that they are less likely for people to know. So let's go ahead and see what happens. Okay. So yeah, it's just a very quick escape. Closes down just that site. So and again, we see that pop up again here. So we can call. They also have an online chat. I don't know anything about the AI chat, and those of you who know me know that I'm a little bit iffy on using AI for things like this because I have some feelings about how AI currently works with marginalized populations and stuff like that. So I don't know that that is like something I would suggest to folks, but we still have the text. We have the live chat option. We have the phone call option. This one also has, I can remember. Oh, this one has a page, I think. Um, Maybe I'm thinking about it different. I must be thinking about it different. I thought this one had a page where you could go click by state. Um, so there's this, but this isn't what I was thinking about. If I remember what there is a website too where you can kind of go and click by state, and that's really nice. Because it can kind of show you everything. I may just have to send that to y'all separately if I can't find this. Okay, so the website I was trying to think of was actually the other website, the domesticshelters.org, which if you come down here to find resources, has a really nice by state or province set up. So you can, so again, we're gonna go with Colorado, and it's just gonna kind of like list out all the areas. We're gonna go with Aurora's, that's where I am. And then it takes you immediately to like, okay, well, here is like your most local, right? And the information about it. So we can go back and we can go to Boulder. And like, here's your most local, right? So just a nice little setup. We can do it by like popular cities, Denver, if you know that they're like near a city, um, and so on and so forth. So this has just like a nice little setup where a little bit of shortcuts for just going by locations. Again, so we've got our National Best Advanced Hotline, and this is for any state. So here's one that we use when we're trying to find local, and then this one is that we can just give to everybody, right? So common IPV assessment tools and resources. We've got the danger assessment, Campbell assessment. This is a lethality assessment tool used to evaluate risk of severe injury or homicide in IPV cases. We've got the HIT screening tool, which we're going to talk about in just a moment, which is a brief screening tool assessing experiences of being hurt, insulted, threatened, or screamed at by a partner. CTS2, conflict tactics scale, is relationship assessment measuring conflict, aggression, coercion, and negotiation patterns. Women's experience with battering scale, the web, measure assessing fear, vulnerability, and coercive control in abusive relationships. And then, of course, we have our local DV and IPV agencies hotlines, which we'll talk about here. So we're going to talk specifically about the HITS scale because this is one of the easier ones to just use very quickly as part of our assessment. So hurt, insult, threaten, and scream. The acronym is HITS scale. This scale is a brief, validated screening tool developed by Kevin Shuren and colleagues used to assess intimate partner violence in healthcare and mental health settings. It stands for hurt, insult, threaten, and scream, reflecting the four domains evaluated in the questionnaire. Clients rate how frequently a partner engages in these behaviors on a Likert scale, allowing clinicians to quickly identify possible patterns of abuse and determining whether additional assessment, safety plan, or intervention is needed. So the HITS HITS scale screening tool. You ask, how often does your partner physically hurt you? Never, really, rarely, sometimes, fairly often, frequently. Insult or talk down to you, threaten you with harm, scream, or curse at you. And they're going to put 1, 2, 3, 4, 5 here. So we're going to total up this score. If so each item scored from 1 to 5, range between 4 and 20. A score of 10 or greater signifies the responder is at risk of domestic violence or abuse. Um, and then we also have the extended hits, the E hits, which adds the question, how often does your partner force you to have sexual activities? Which is probably a good one to add. Okay, so take a deep breath. This is not the most fun topic to talk about. Definitely, take care of yourself when, you find yourself getting activated around this topic, and you will work with folks who experience coercive abuse. You will work with folks who experience physical abuse. You will see this in couples and partners. So this is something that we need to be doing our own therapy on, our own self as a therapist. As a final reflection of this, I would love for you to take a moment to think about how you, as a systemic therapist, maintain a systemic perspective without minimizing abuse, coercion, or safety concerns. So pause, take a moment to think about that, and please reach out to me if you have any questions.